Now, a little bit about drug development, just to mention it. I mean, this field is so ripe, and I think that compared to when pretty much all of us, looking around, when we started our training and around that time, that we didn't have as many novel agents and exciting agents. And now it's getting to the point where we need to really have the data from clinical trials to know how to best optimize these agents, but also as we're working on the old agents, new ones are coming in and being incorporated. So it is difficult but exciting, and I'm sure we're up late looking at all this stuff. But with respect to Hodgkin lymphoma HDAC inhibitors, we did mention, there's penobinostat, but there is other subtypes of erinostat and mesetinostat, and they all have about 20% single agent activity as single agents. And I think as a class, one thing that's very unique when you give a prolonged exposure to these is the fatigue criteria. I mean, a lot of patients just feel drained physically. They feel like they get out of bed, they can do things, but they just feel very tired. Have any of you actually experienced that with your patients? We'll start with Andre. And have you done anything to try to help that along?
Yeah, Myron, excuse me, Myron, I agree with uniqueness of this drug, of this class of drugs. And what's interesting that I think we're observing that some of the HDAC inhibitors are more targeted than others, and some of the classes of HDAC they inhibit might be more responsible for toxicity versus efficacy, and all of us probably have seen similar observations. To kind of support this suspicion, erinostat is a pan-HDAC inhibitor, and interestingly, even though it's an oral agent, we have seen more toxicity with it than, say, romidepsin, that is a more targeted HDAC inhibitor. This is kind of just an observation, but I think there is much more to learn about these agents. And I think the most exciting part about HDAC inhibitors, these are epigenetic drugs that I think in the future we'll learn more how to use it in combination with standard chemotherapy to sensitize tumor cells. I think it's exciting to see a signal, a single agent, but I think the future of this drug is really in combining them with either other biologics or chemotherapy agents in attempt to epigenetically modify tumor cells and break our biggest problem, which is resistance.
Very good. I think also we'll be talking a little bit later on a panel a little bit about romidepsin as well. We discussed the T-cell lymphomas. Any experience with the group? I know myself with refractory and patients that have limited options that there is a little bit of data with lenalidomide in these patients. And it's interesting because, as we all know, that Hodgkin lymphoma is actually, the Reed-Sternberg cell is not the predominant part of the actual involved lymph node. They're small numbers, and it has a very, very reactive type of surrounding cells in the microenvironment. And it would make maybe logical, some of the hypothesis, by using a drug such as an IMiD, that it would have a very high response. I'm just curious, we'll ask maybe starting with Steve, your experience, and maybe Anas, with respect to the use of lenalidomide. Do you use it occasionally, and what experiences have you had with it?
Yeah, I've not used it as single agent Hodgkin's. There's little data which others may talk about in more detail. We have an ongoing study combining it with romidepsin for lymphomas in general, and we have treated Hodgkin's patients and seen some response. Now, being able to tease out whether that's the lenalidomide, the romidepsin, or some combination is a little early, but I think there's something to that story.
What do you think, Anas? Have you used it or considered using it?
I have used it rarely. There's 2 phase 2 trials reported single agent activity of lenalidomide. Both have about 15% response rate. So it has some activity. It doesn't stack up high in the list, but if you need desperately to help a patient who is symptomatic and have no other options, it wouldn't be wrong to test it because it has some single agent activity.
I know that at Northwestern University, my friend Steve Rosen, from a panel discussion, he said that they often try to utilize lenalidomide to bridge patients to try to get them to transplant. It has variable success, we know, but I guess I think that's a reasonable thought that if you have tried the other approved agents, that it might not be unreasonable to give it a shot in some patients.
I think one agent that's not approved in this setting that might have a higher response rate is everolimus. I've been really impressed with having participated in the phase 2 trial that there are patients that are totally refractory to chemo, relapse immediately after transplant, and have had over 3 years duration of response, are still on that trial, in fact, with everolimus, and have a totally normal quality of life. So I think maybe that's a drug that may be underutilized in this setting.
So with respect to targeting the mTOR and PI3K type of target. And does anybody really use bortezomib single agent? I mean, I personally don't use a lot of it as a single agent, and Hodgkin's disease? And
0% response rate, single agent.
yeah. So the combination, the only thing of interest is that although a lot of the agents, sorry, not a lot, a number of these agents have very limited activity, but I think we mentioned it before, is that the future may hold that if there's an important target, and even though it might not kill the cells, if we're tweaking the inside the cell, maybe some of the pathways, it may be able to be used in combination. I think that we can't give up on drugs necessarily because they don't work as single agent and have a great, robust, they don't have the activity we've seen with ibrutinib and with maybe idelalisib, but when we combine them, we might actually see excessive, really great activity. But again, good trials and good preclinical data is needed. Why don't we move into the last segment? And before we do that, I just had one other question actually for Dr. Yunus Farnas. There was actually some interesting data where rituximab was being utilized, and you ran the study and you did this when you were at MD Anderson, looking at using rituximab, not necessarily, there are some Reed-Sternberg cells that are CD20 positive, but as we just discussed, the microenvironment around the Reed-Sternberg cells is ripe with activated T cells and B cells and macrophages and all types of different cell types. And I guess the question is, why did you have an idea to utilize the rituximab? And with the trial with the rituximab BVD, what were your findings?
Right. So CD20 in the microenvironment have several roles. You can think of it as potentially providing growth factors to tumor cells, so eliminating it may be of value. There's some belief that B cells may put brakes on T cell activation, so if you eliminate them, you can facilitate T cell response against tumor cells. And some, especially the group from Johns Hopkins, reported that the Reed-Sternberg cell stem cell is of CD20 expressing cells. So there's several rationales for using rituximab to eliminate normal reactive B cells from the microenvironment. So we've done a phase 2 trial initially and we found some responses, then we moved it to a combination with ABVD, so it became RABVD. And there's 2 phase 2 trials reported last year, one from MD Anderson, one multi-center, led by Johns Hopkins. Both showed similar results, that there's some high activity seen, at least in non-randomized fashion. So what we did, we moved it to a randomized phase 2 trial in multi-centers. But in the meantime, of course, brentuximab showed up on the radar screen. So the use of rituximab didn't become as a priority for the community as a whole. Whether this will be of interest for further development, I don't know. There are now more hot antibodies are in development, like PD-1, PD-L1 targeted agents. My guess that those will take higher priority in the future development in the naked antibody field.
Thank you.